Ladies and gentlemen, welcome to Triple N Media. I am Dr. Nik Nikam. I've been a cardiologist for more than 40 years in the Houston area, and the focus of this presentation is ACC AHA 2021 Guidelines for Management of Patients with Chest Pain. So let us begin with the feature presentation. This presentation is a comprehensive review of how you evaluate a patient with chest pain at various age groups, with various presentations, under various risk factors and varied conditions. This is based on the 2021 ACC AHA guidelines published in circulation in 2021. Here is the reference. If you would like to, you can just Google this title and you can get a PDF copy of this article for free. They have the acronym chest pains, which stands for chest pain which can be cardiac or non-cardiac. We are going to talk about high sensitivity troponin that will help us to identify cardiac patients. Early, it is very important to seek early medical help in the presence of acute chest pain, and as a physician, it is our duty to have a shared decision making, because most of the patients today consult Dr. Google before they ever come and see a cardiologist. So you need to be as knowledgeable as Google as what the patients are being educated about, their symptoms, their presentations, so that you are in a much more knowledgeable position to explain to the patients as what is going on. And of course, the testing. And when it comes to the word pain, it is clinical decision-making pathways and accompanying symptoms or risk factors, identifying patients who might benefit from tests, think about non-cardiac causes of chest pain, and structured assessment to be used. Anyway, this is not a free-flowing acronym, but most of these guidelines are based on randomized large clinical trials. They are based also on observation trials. They are based on expert opinions, and they are classified into different classes. Class 1, which has a strong evidence based on the literature that the benefit far outweighs the risk. So anything that is class 1 indication for a given test or a procedure or a treatment should be imprinted in our minds as cardiologists. And what we are going to learn today is going to be good for the next 5 years, as these guidelines are not produced every year for different chapters in cardiology. Class 2A is a moderate evidence of benefit which outweighs risk. And of course, class 2B is sort of plus minus. That's when you have to think about, is this going to harm the patient? Are we going to get any marginal benefit from the procedure or the treatment? And of course, we need to know every class 3 indication for any procedure or treatment or management, because the risk outweighs the benefit. So if you want to practice guidelines directed medical management or interventional management, I think we should stick to this as the best guide to decide what we need to do next in order to help the patient sitting across our since most of these patients consult with Dr. Google and they all come with a long list of questions, it is important for us to be having a shared decision with the patients and answer each and every one of their questions so that we can keep up with the patient's knowledge about the subject even before they come to see us. Now let's look at some of the things that we need to be considering when a patient with chest pain presents to the office, to the emergency room, or in any other situation. Anytime somebody has a chest pain or sensation in the chest that should not be there, heaviness, shortness of breath, or crushing sensation, it should be considered cardiac until proved otherwise. When we are talking about chest pain, as cardiologists or fellows, or residents, or doctors, we need to be more descriptive in explaining the symptoms when we are taking the history. Calling it as atypical could be misleading the patient and also the physician in terms of making appropriate diagnosis and treatment. Here is a chart which shows the nature of the cardiac pain compared to non-cardiac pain. This is not cut and dry, as not all cardiac patients present with chest pain. They can present with shortness of breath, they can present with dizziness, they can present with many other symptoms, fatigue, but these are some of the symptoms of real acute episode of a myocardial ischemia due to subtotal occlusion of an artery or due to exercise-induced ischemia or due to total occlusion as in case of a STEMI. In these patients, the chest pain is generally located in the central area, has a severe pressure-like sensation, squeezing, gripping, radiating to the left side, or tightness. It is exertion-related, and it is retrosternal, left-sided. And as we move to further to the right side, you can just look at these. These are non-specific symptoms which may not be related to the heart or myocardial ischemia. It is quite interesting from this chart that at each age group between ages 18 to 44, which is supposed to be the lowest risk for coronary artery disease, yet almost 45 to 50% of the people have non-specific chest pain. As we look at the moderate and high risk group, still 50+% of the patients who present to the emergency room have non-specific chest pain. That should be of great significance when we are evaluating patients with chest pain, no matter what their age group is. However, as we get into the moderate and high risk groups, we see coronary atherosclerosis comes next to non-specific chest pain. So if this is non-specific, if it's not non-specific chain, the second thing we need to rule out is this related to myocardial ischemia? Is this related to coronary artery disease? So let's keep that in mind. At ages 45 and beyond, anytime somebody presents with chest pain, the first thing we need to consider is this cardiac pain? You only exclude non-specific chest pain after you have done the cardiac evaluation and decided this is non-cardiac chest pain. When we are taking a history, as I described the symptoms of typical cardiac myocardial ischemia pain, these are some of the things we need to focus upon, which is drilled upon when we are in the medical schools or doing cardiology rotation. The length of symptoms, are they there for 1 month, 2 months, 6 months, or years? Location, character, duration, radiation, aggravating factors, relieving factors, risk factors, and previous history of chest pain or any evidence of heart disease. So these are all things that should be included in our history. If you are talking about patients who are over the age of 75, we should also consider not only chest pain, but we should also look at shortness of breath, syncope, delirium, and unexplained falls or extreme fatigue. All of this could be an indirect sign of coronary artery disease in the population beyond the age of 75. In women, the chest pain is not directly correlated with the significant coronary artery disease as such. What I mean to say is the chest pain is not as reliable as in men as an indicator of myocardial ischemia. Their chest pains are less descriptive. They may have more shortness of breath or some kind of a sensation which they can't describe, or they may have more like GI symptoms like heartburn or indigestion, something like that. Then, when we are talking about cultural diversity, which is one of the hallmarks of the United States, we also, as physicians, face challenges with reference to languages, perception of pain from in different ethnic groups, and of course the description of chest pain. And in these circumstances, it is imperative that we have an interpreter and take appropriate history as we would normally do with other patients. We should also specifically ask them, have they restricted their activities, which may be an indication that they are trying to limit their activities to a point where they don't get any symptoms. If someone is experiencing an acute chest pain, which they didn't have before, the first thing to do would be to call 911. This is not the time to second guess your pain or go Googling for alternative diagnosis. When we are seeing someone with an acute chest pain, we need to do a very focused cardiovascular evaluation. We look at their pulses, look for any pulse differences in the arms, look for the carotids, look at the chest, listen to the heart sounds, listen to the lungs, make sure there are no absent breath sounds, and check for the abdomen and look for any evidence of edema, things like that related to cardiovascular system. It has to be very quick and focused to the cardiovascular system. And once we have established if this is not a cardiac pain, then we need to consider differential diagnosis such as aortic dissection, pulmonary embolus, pleurisy, pericarditis, esophageal rupture, and other things that can cause chest pain like gallbladder attack. And here are some descriptions of typical acute coronary syndrome, pulmonary embolus, aortic dissection. I don't want to read each one of these. You should familiar, especially if you're a medical student, a resident, or a new fellow, you should kind of memorize these things. Cardiac patients present with diaphoresis, tachycardia, and sweating, along with maybe a gallop or a murmur. Whereas pulmonary embolus, there is tachycardia, dyspnea, hypoxia, and there may be a history of DVT or deep venous thrombosis. Aortic dissection is like once in a lifetime experience of a crushing chest pain where a patient may just collapse and the chest x-ray may show enlarged aorta. And as I said, 10% of these patients may present with syncope and 40 to 70% of them may have aortic regurgitation. The rest of the stuff, I'm just going to let you pause this video and listen to that. Pause this video and watch this one. When it comes to pleurisy or pericarditis, you may be able to hear a rub. You hear a rub that may be helpful. If it's pneumothorax, we may be unable to hear breath sounds on one side compared to the other side. If it's pneumonia, we may be able to hear rouse, costochondritis. You can feel some joint tenderness. Anyway, so whenever someone presents to the office or to the emergency department, the best thing would be to get an electrocardiogram within 10 minutes. If it is in the office setup, while we are getting the electrocardiogram, we should also make arrangements for the emergency medical team to transport the patient to the nearest hospital setting. And in all patients who present to the emergency department with chest pain, in addition to getting an EKG, we should get the high sensitivity troponin N. And one thing we should not do, for which some of the doctors have been sued in the past, and that is doing unnecessary tests, drawing blood tests for troponin in the office, or sitting and doing an echocardiogram and delaying the transportation of the patient to the emergency room, because time is life. Time is heart muscle, especially if the person is having an acute myocardial infarction. So remember this class 3 harmful, and of course electrocardiogram should be obtained in all patients, And if the electrocardiograms, whether they are normal or abnormal, we should get serial electrocardiograms. And if the person has a STEMI or a non-ST segment elevation acute coronary syndrome, they should follow the STEMI protocol or the non-ST segment elevation ACS protocol. And there are certain circumstances when they may be having real significant crushing chest pain and the electrocardiogram may look normal. In those situations, it is reasonable to do extended chest leads like V6, 7, 8, 9 to look for any posterior infarction, or right-sided chest leads to look for right ventricular infarction. So to sum it up, when someone presents with a chest pain, we get the history, we do a quick cardiovascular examination. If the EKG shows a STEMI protocol. If the EKG shows STT changes, diffuse ST elevation, then consider pericarditis. If there is ST depression and T-wave inversion with borderline troponins or normal troponins, acute coronary syndrome, non-ST segment elevation. If the EKG is non-diagnostic or normal, then repeat the EKG and the enzymes. If they are positive, then put them in the acute coronary syndrome box. If you are not sure, you can do extended leads. If the EKG is normal, they have normal troponin, then you look for any arrhythmias. If there are no arrhythmias, then they can be treated medically. Now coming to the biomarkers. The most important biomarker that we would be using would be troponin. If the troponin is 3 times normal, then that's a very strong indication that we are dealing with a non-cardiac pain, in the sense it is not ischemia-related pain. We have to understand that the high sensitivity troponin could also be elevated in patients with myocarditis or pericarditis. CKMB, which we used to do routinely for decades, is no longer considered beneficial in evaluating patients with chest pain. Here's a chart which sort of puts the same things that we talked about in the flow chart, but I don't like some of the things that are mentioned here. If it's low risk, you need no testing. I mean, I don't agree with that, because the patient may be low risk, but if they have associated other risk factors, then we need to evaluate each individual on their merits. In the intermediate and high risk group, if they are not having like acute myocardial infarction, we can do like perfusion studies to look for any evidence of inducible myocardial ischemia. The key factor is inducible myocardial ischemia. In low-risk patients, we can do coronary calcium score as an outpatient, but it doesn't have to be done during the same visit. However, if you're dealing with an acute unstable patient like acute myocardial infarction, or a patient with ongoing chest pain with non-ST segment elevation, they can go for cardiac catheterization and any intervention that may be necessary. Coronary computed tomography angiography, that is CTA, that's coronary tomographic angiography versus stress tests. Somehow the 2021 guidelines give a lot of importance to the coronary CTA, but I want to underscore that, first of all, coronary CTA is not readily available in many institutions. They are not readily available round the clock. There are problems with the resolution of the coronary CTA. Then we have the problem of calcium with blooming effects in older individuals. So there are several limitations, but nonetheless, in centers where coronary CTA is available, it may be the quickest way to find out if someone has coronary artery disease. In that sense, coronary CTA is extremely useful in ruling out coronary artery disease in younger population, but it may not be useful in patients with existing coronary artery disease with heavy calcifications, which can be distorting the images, or in patients with aortic calcification and other things that can give false positive results. In addition to that, we also need experts to read these things, because if we are getting this, the images mismatch, or the contrast injection was not appropriate, and all kinds of excuses that are given by interpreters, it's going to be a worthless test. Whereas stress imaging is extremely useful in not only assessing the presence of ischemia, the location of ischemia, the extent of myocardium involved, and also the left ventricular function. So there are so many different things that we can get from a stress imaging, such as spect, MPI, PET, or CMR. These things are quite useful in not only assessing the anatomy of the coronary arteries, the circulation, but also assessing the functional significance of any evidence of ischemia that we are seeing along with the assessment of the left ventricular function. And here are some of the benefits of various types of non-invasive studies that we have to evaluate patients who have borderline EKGs, whose enzymes are normal. And here we have exercise treadmill test, stress echocardiography. But again, with stress echocardiography, we have to understand these patients should have very good echo windows to get good delineation of the left ventricular cavity. But now with contrast, that has become much easier. But again, we can't use drugs like dobutamine in patients with arrhythmias or tachycardias. SPECT MPI is very useful. We can do a stress test, or we can do a pharmacological stress test, and we can also look for evidence of scarring in the myocardium. And same thing with the PET and CMR. Of course, PET and CMR may not be readily available in many centers, especially CMR may be available in only major medical centers, whereas PET may be available in intermediate centers. But SPECT MPI is a pretty good test to look at the left ventricular function, the presence of ischemia, the extent of ischemia, and its effect on the overall heart function. Okay, again, with chest pain, we have examination, and we have to look for potential cardiac causes. If there are no potential cardiac causes, then we need to evaluate for non-cardiac chest pain. If it's a STEMI, we go this way, and then if it's not STEMI, if we suspect the etiology if it's not STEMI, then we need to consider acute coronary syndrome, other differential diagnosis I talked about, like dissection, pulmonary embolus, myocarditis, pericarditis, or valvular heart disease. First, we need to categorize these patients into what risk group they are. Are they low risk group? These are the younger people with no risk factors like hypertension, diabetes, high cholesterol, or they may have some smoking, which is a very good risk factor. And then we need to categorize them as low risk, intermediate, or high risk group. That will help us to stratify as what we need to do next with these patients. Then, of course, we're going to depend on high sensitivity troponin. If it's normal, it can be repeated in 1 to 3 hours. But if you're doing a regular troponin N, that can be repeated every 3 to 6 hours. So first find out what kind of troponins are assayed in your hospital settings, and then follow up with these guidelines so that you can have answers quicker than if you don't follow the guidelines. Of course, all standing orders for chest pain should have a troponin protocol. Like you draw the troponin at the time of arrival, 1 hour or 3 hours or 6 hours. You have a specific protocol depending upon the type of troponin assays that are done at your institution. If someone had a chest pain 3 hours before they arrive in the emergency room, And if the EKG is normal and the troponin is normal, they say you can almost exclude myocardial injury. So there is no evidence of myocardial injury, but that does not exclude the presence of non-obstructive coronary artery disease. So again, we are going to look at this chest pain as with the history and examination. And if the EKG is normal, we look for non-cardiac causes for chest pain. If it's a possible acute coronary syndrome, we follow up with the troponins, and based upon the troponins, if the troponins are normal, if we are dealing with a low-risk candidate, they can be discharged home, and any further testing such as coronary calcium or other stress tests can be done as an outpatient. If it's an intermediate risk, they need to be admitted to the hospital and observed. If it's a high risk, they go for coronary angiography. A normal coronary angiogram with no stenosis or plaque detected on ccta gives a warranty period of 2 years. That means you may have to check that like every 2 years if the patient is having recurrent symptoms. Whereas normal stress tests given adequate stress has a warranty of 1 year. That's kind of real low. Here is an important point. If you have normal troponin levels times 2 with a normal EKG, there is a 99% negative predictive value of 30 days major adverse cardiovascular events. So that's a pretty good index as to what the outcome is going to be based on the troponin levels alone. Here it's saying the same thing. If someone presents with a chest pain, a 30-day risk of death or major adverse cardiovascular events is less than 1%, and they should be designated as low risk. And these patients can go home and follow up in the office setting. If we are dealing with an intermediate risk patient who has borderline EKGs, who has maybe borderline troponins, maybe normal one, the second one just mildly elevated, then an echocardiogram could be obtained to look at evidence of any pericardial disease, evidence of wall motion abnormalities, left ventricular size, function, aorta, and all the other structures we can do evaluate with the echocardiogram. And these patients should be admitted to the observation unit for further evaluation and management. Intermediate risk group with no history of coronary artery disease in the past can have ccta. But again, as I said before, the coronary CTA is useful in ruling out coronary artery disease. If it's entirely normal, it's well and good. However, if there are technical issues, if there are interpretation issues, if the equipment is not available at the center, then this becomes remote. And in the intermediate risk group, who has abnormal EKGs, who has mildly elevated troponin levels, who has ongoing chest pain, then intravenous, then coronary angiography would be the preferred method. It is a class 1 indication for those patients. If you are dealing with an intermediate risk group where the enzymes, troponins are normal, but borderline EKG changes, we could consider like a spect, PET, and if it's feasible, if you have the facilities, CMR. Some of these patients have chest pain and no known coronary artery disease with a coronary artery stenosis of 40 to 90% in a proximal or middle coronary artery on ccta. If you see 40 to 90% stenosis, do the fractional flow reserve, or the fractional flow reserve may be measured during the ccta to assess the significance of the anatomic stenosis. So when we are dealing with 40 to 70% stenosis, there's always a question as how significant is this stenosis functionally? Is this causing the symptoms? In which case, the fractional flow reserve will be very useful, and if you can do that with the same ccta, it may be beneficial. Then we are talking about very few centers in the country who have these facilities to perform accurate assessment where it would be useful. Now let's look at the intermediate risk with no known coronary artery. This is sort of summarizing all those things we have talked about, the intermediate risk group. Prior testing, if they had a prior testing, if the recent test was negative, you can discharge them. But I don't know if I'm going to agree with that scenario. Yeah, I would evaluate them for at least 24 hours before I make a decision based on what I see during those 24 hours. If the previous test was inconclusive or mildly abnormal stress test, then they say you can do coronary CTA. Again, as I said, coronary CTA may not be feasible in many centers, in which case this whole thing will be sort of obsolete. If there was a severe abnormality, then of course they need to go for coronary angiography. Assuming that we do not have the facilities for coronary CTA, then the next best thing would be to evaluate them for any evidence of reversible ischemia or do cardiac catheterization, and if there is no evidence of reversible ischemia, then maybe guideline directed medical therapy optimization is the way to go. If there was no prior testing, we could consider a stress testing like spect, PET, or CMR, and based on that, if it's negative, they can be discharged, and if it's abnormal, they go for cardiac catheterization. If ccta is inconclusive, non-obstructive CAD, they can go home. If it's a high risk of CAD and they need to be evaluated with, of course, angiography, and they can have the FF or functional flow reserve by CT. If that is positive, then they go for a coronary intervention. If FF or CT is not suggestive of functionally significant coronary artery disease, then they can be treated with medical treatment. If we are dealing with an intermediate risk group with acute chest pain or worsening pain with history of coronary artery disease or history of prior revascularization, they should go for coronary angiography. If we are dealing with an intermediate risk group with the coronary artery disease, again they say we can consider ccta. Again, I pose these questions about the testing capabilities, interpretation expertise, and many other things. Of course, if you are dealing with an intermediate risk group with coronary artery disease, if they have 40 to, I don't know why they say 90%, anybody who has 90% would most likely get a coronary intervention. It is usually between 40 to 70% when we look for functional flow reserve, which help us to understand the functional significance of a given stenosis if the patient is having significant symptoms. Intermediate risk group and coronary artery disease, of course, these are the tests that are available, which we talked about. Let's move on. Intermediate risk with known coronary artery disease. This sort of summarizes what I have said about the intermediate group with a history of coronary artery disease. So you can just look through this chart, and if you are having a patient with this type of presentation, maybe it's good to revisit this chart and see what we need to do. In patients with coronary artery disease, let me summarize this entire chart with a couple of sentences. The most important thing we need to determine is this symptom related to the heart? Is this symptom indicative of reversible myocardial ischemia? That is the main question we need to answer, because we know the patient has coronary artery disease. The next question is this patient having progressive coronary artery disease leading to reversible ischemia causing chest pain? If it is so, is the reversible ischemia related to significant stenosis, how significant the stenosis is, and then make the decision as whether they go for medical treatment or coronary angiography and coronary intervention. Let's move on. High risk patients with coronary artery disease, chest pain, ischemia, ejection fraction, it should be EF, I'm sorry, less than 40%, stress test positive, and these patients should go for coronary angiography. These are the high risk patients. Those who have history of coronary artery disease or multiple risk factors, ischemia, reduced ejection fraction, and a history of positive stress tests in the past. The other high risk patients would be patients with no coronary artery disease but have chest pain, elevated troponins, and they can go for a CMR and echocardiography. Now let's talk about patients with prior history of coronary artery bypass surgery. Again, as I see, the coronary CTA has been promoted quite extensively in these guidelines, but I am concerned about how many facilities have coronary CTA and how good are the procedure techniques and how good are the interpretations. If they are all excellent, then yes, by all means you can go for coronary CTA. But otherwise, I would go for coronary angiography, and before that, we could possibly do a myocardial perfusion imaging to look for the location of the ischemia, the extent of the myocardial ischemia, and the overall left ventricular function. In patients having dialysis who have chest pain, they must be transported to the emergency room for evaluation. The chest pain could be related to many things. A lot of renal patients have uremic pericarditis. It may be related to uremic pericarditis, or it may be related to coronary artery disease as they have accelerated atherosclerosis and presence of coronary artery disease. So they must be evaluated thoroughly in the emergency department setting. One thing I learned in his guidelines is that we should routinely ask for the use of cocaine or meth while taking history. So it doesn't matter the age group, because in institutions where I used to work, there are patients who had used these drugs and came to the hospital with chest pain because of cocaine. Of course, we have to be getting the patients involved in decision making, which we already talked about. Then we talk about non-ischemic chest pain. When we are dealing with non-ischemic chest pain by looking at a normal EKG and normal series of troponins, we should be thinking about other conditions. But what happens in the emergency department, let me explain to you. If someone comes with chest pain, if they have a normal EKG, and if their initial troponin level is normal, they have no history of coronary artery disease in the past, it is almost like a knee-jerk reaction for the ER physician to order a chest CT to rule out pulmonary embolus. And it happens so often at so many institutions. Now think about it. Now we've given 150 cc's of contrast to this patient, and later on, if the second troponin level comes back as elevated, now you have an acute coronary syndrome patient who may, in the future, in the next day or two, may need cardiac catheterization. So you are going to give them a contrast overload. But that's the reality that we face. That's something we need to keep in mind. So when we are dealing with non-ischemic chest pain, we should think about pulmonary embolus, pericarditis or pericardial effusion, aortic dissection, endocarditis. This is very uncommon for endocarditis to present with chest pain. If you're dealing with aortic syndrome, if the patient has history of Marfan's syndrome, if the patient has chest pain, and if their chest X-ray shows widened mediastinum, then chest CT angiography of the chest would be of great importance in identifying aortic dissection. When you're having a patient with aortic syndrome, we could also do an echocardiogram to look for the aortic root size and aortic valve function, CMR or a CT. If we can't do CM CMR if we can do a CMR if we can't do CT because of the kidney function. Suspected pulmonary embolus, CTA, already talked about that. Suspected myocarditis, then myocarditis may be related to myocardial trauma. If somebody is having a myocardial trauma, the best test would be CMR, which can look at myocardial contusion, myocardial scarring, myocardial damage, and pericardial effusion, and all the other features. Again, in patients with acute chest pain with suspected myocarditis, CMR is much more useful in identifying inflammation versus coronary stenosis causing chest pain. And in patients with acute chest pain suspected of myocarditis, echocardiogram might show evidence of pericardial effusion or wall motion abnormalities. In patients with pericarditis, an echocardiogram or a CT may be quite useful in identifying pericardial effusion. Chest pain with valvular heart disease. If you're dealing with chest pain, patient with like aortic stenosis, mitral regurgitation, or mitral stenosis, of course, echocardiogram will be of paramount importance in looking at the velocities, looking at the degree of stenosis, along with any wall motion abnormalities. And in certain patients, we may have to do a TEE to look for any significant intracardiac shunts. In patients suspected with patients having chest pain with known suspected valvular heart disease, CMR could also be equally useful if it's available in your institution to look at the valves, their structures, their function, and also look for the myocardial size and function. Evaluation of acute chest pain with suspected non-cardiac causes. Of course, some patients may present with recurrent chest pains, which may be non-cardiac, but we need to evaluate them even if they have negative stress tests or refer them for evaluation by other specialties. There's a long list of differential diagnoses when it comes to chest pain, and this is something you have to narrow it down based upon their presentation, physical examination, EKG, cardiac enzymes, and the other things. Behavioral therapy. Anxiety could be a major component in some of these patients causing chest pain, or chest pain can bring in an anxiety episode. Especially when somebody is having a heart attack, their anxiety levels are going to be pretty high. So psychological evaluation and management is of great importance when we are dealing with cardiac or non-cardiac patients with chest pain. Patients with sickle cell disease and chest pain, they need to be transported to a facility in a hospital setting where they can be managed with hydration, fluids, and evaluation of their chest pain. The pre-test probability of obstructive coronary artery disease in symptomatic patients. So here's a nice chart which tells us about how to sort of grade these patients as low, moderate, or high risk based upon the age group. The chest pain being cardiac is very low in the age group 30 to 39. And as we get older, the chances of this being cardiac gets higher in men, women, and same thing with dyspnea here on this side. So based on this, we can look at and see, depending upon the age and the presence of a coronary artery calcium, we can say the risk could be less than 15%. The pre-test probability based on age, sex, symptoms, and coronary artery calcium, we can categorize them into three groups. If their calcium score is 0, they are very low risk. If the calcium score is between 1 to 1,000, it ranges from 15 to 50%. If their calcium score is greater than 1,000, the risk of having coronary artery disease is greater than 50%. So with just chest pain or shortness of breath, patient's age, and a coronary artery calcium. So this is a very simple, non-invasive test which does not involve any contrast, can be done and should be done in the especially in population 60 or older, so that we can identify those who are having high calcium score and treat them appropriately. Look for any evidence of reversible myocardial ischemia and address that at the early stages so that we can preserve the myocardial function and left ventricular function. In an outpatient clinic, as I said, we can do a coronary CTA. We can also do a stress test to further evaluate these patients if they have stable chest pain and they have normal electrocardiogram. Stable chest pain, no known cardiac disease. So this chart sort of summarizes what we have been talking about in the past few minutes. I'm not going to go through this again, but this is an excellent chart to keep or put it on your bulletin board so that when you see somebody with no history of coronary artery disease, who has stable chest pain, whose clinical risk assessment is done, and if they are low risk, younger population, and we can do a coronary artery calcium score. If that is normal, then we can follow them medically. If the coronary calcium score is high, they are in the intermediate risk group, then we need to consider coronary CTA or stress imaging of some type to evaluate them further and decide. Whereas if the stress imaging is showing evidence of myocardial ischemia, then we need to consider optimize medical treatment and then consider coronary angiography. Stable chest pain. If they have inconclusive ccta, a stress imaging may be reasonable, but I would go for stress imaging as the first modality because I can look for evidence of myocardial ischemia. I can look at the location of the myocardial ischemia, the extent of the myocardial ischemia, its functional significance, and left ventricular function. That's my approach. Patients with known CAD presenting with stable chest pain, we can optimize their medical treatment. Then we can also focus on their risk factors: obesity, smoking, high cholesterol, hypertension, lifestyle changes, exercise. All of these things can be re-emphasized, taking this opportunity to optimize their cardiovascular system. Stable chest pain with known coronary artery disease. Again, I think this all boils down to the patient is having chest pain, but it is stable, and they have a history of coronary artery disease. My next question is this patient having reversible ischemia? If so, what is the location of the ischemia? What is the extent of the myocardial ischemia? And what is the function of the left ventricle? And what is the amount of myocardium involved, which can be easily determined by stress imaging. And if the stress imaging is abnormal, then they go for cardiac catheterization and coronary intervention. Here they recommend ccta and functional flow reserve by CT. Then again, if you find lesions between 40 and 70%, then you're still stuck as to what to do if you can't make the decision. They say if the FFR is greater than 80, that means normal circulation, then we just follow them medically. If the FFR is less than 0.8, then they go for cardiac catheterization and coronary intervention. Same thing here. In patients with prior coronary artery bypass surgery with stable chest pain, if there is evidence of ischemia, my main crux is on, does the patient have reversible myocardial ischemia? We know this patient has coronary artery disease. This patient had coronary artery bypass surgery. Now the patient has pain. Does this patient have reversible myocardial ischemia? If the patient has reversible myocardial ischemia, the answer is coronary angiography. Otherwise, it says stress imaging as 2A, but I would first do the stress imaging to look for evidence of myocardial ischemia, reversible myocardial ischemia, and if it is yes, then go for coronary angiography. So I would first do the stress imaging before I do coronary angiography in a patient who is stable We are almost towards the end, ladies and gentlemen. In patient with non-obstructive coronary artery disease, that means they have an obstruction, but it is not significant, but they keep having symptoms. If they keep having symptoms, then we need to determine, are these symptoms related to the obstruction that we are seeing, which could be 40, 50, 60, 70%. And how do we determine that? We can do a ccta functional flow reserve by CT, or we can do a stress imaging, or if you're in a cardiac cath lab, you can do a functional flow reserve in the cath lab. So those are some of the ways to determine the functional significance of a non-obstructive coronary artery disease causing symptoms. It's called the INOVA. Basically, I have summarized here, I would look for reversible ischemia in patients with non-obstructive coronary artery disease who shows evidence of ischemia. If they show evidence of ischemia, how significant is the ischemia? If the ischemia is involving 5% or 8% of the myocardium, they can be treated medically based upon the nuclear studies long-term follow-up. If they are having ischemia of greater than like 10-15% of the myocardium, then we need to go for coronary angiography. So again, this INOCA, that is ischemia with non-obstructive coronary artery disease, these are all new terminologies which we need to get used to. And this is the protocol we need to follow. We talked about the coronary part this side. If they are having non-obstructive coronary artery disease with ischemia, then we need to look for non-cardiac pain or vasospasm or cardiomyopathies. We can do a stress PET or stress CMR or even a stress spect also, or even a stress echocardiography. If there is no evidence of reversible ischemia, they can be followed with medical management. If there is reduced myocardial functional reserve, this is normal myocardial blood flow reserve. If there is reduced myocardial blood flow reserve and ischemia, diagnostic criteria for CMD plus ischemia should be evaluated. And if there is reduced no ischemia, diagnostic criteria for CMD should be evaluated. These are the patients which have elevated. So ladies and gentlemen, this is the summary of the 2021 ACC AHA guidelines for evaluation and management of patients presenting with chest pain. I hope this has been educational to you. I also have a presentation on 2021 guidelines, ACC AHA guidelines for coronary interventions and for coronary revascularization by Cabbage. Please watch them. And I also have a 2022 presentation on ACC guidelines for treatment of heart failure patients. Please do watch them. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel, and I will see you in the next presentation.